Hey, BC here for BC Nephro. Thanks for watching. I'm Dr. Brian Cronin, board certified nephrologist and clinical specialist in hypertension. Today, I'm going to go over an unusual cause of hyponatremia, referred to as translocational hyponatremia, and I'm going to describe two cases in which I was involved. Most often, hyponatremia is referred to as hypotonic. In these cases, the serum sodium is decreased relative to serum water, which results in a decrease in the serum osmolality. Because of this, there is an osmotic gradient for water to go from the extracellular space to the intracellular space, and this results in cellular swelling. And this cellular swelling, particularly in brain cells, explains some of the complications, particularly the CNS complications of severe hyponatremia. However, there's another pathophysiologic mechanism in which hyponatremia can occur. In this case, there's the addition of another osmotically active substance to the blood. Water then goes down the osmotic gradient in reverse from the intracellular space to the extracellular space. These cases will not be associated with cellular swelling and the same symptoms or complications. These cases are not hypotonic, they're isotonic or may be even hypertonic. This is most commonly seen in severe hyperglycemia, HHNK. The blood sugar is very elevated. This creates an osmotic gradient for water to come from inside the cells to the extracellular space, and the sodium is decreased. There is hyponatremia. In these cases, treatment of the hyperglycemia allows for the water to go back from the extracellular to the intracellular space, and the serum sodium normalizes. However, there are some other causes of this translocational hyponatremia that are less common but are well described, and there's two cases that I've been involved in. The first case was maybe about 10 or 15 years ago, and it was a case of IVIG associated hyponatremia. This was a woman who was receiving a course of IVIG as an outpatient for a neurologic condition. She presented to the emergency room and was found to have severe acute kidney injury and severe hyponatremia. She required acute hemodialysis, although ultimately both the acute kidney injury and hyponatremia resolved. Now, IVIG has been associated with hyponatremia described by several different mechanisms. The first mechanism is actually pseudohyponatremia. The IVIG contains proteins, and the additional proteins in the body can cause an artifactual measurement of the serum sodium. In this case, the serum sodium actually is normal, and if it's checked by a different mechanism that does not involve dilution of the serum, you will get the normal sodium value. But in this case, I believe there was translocational hyponatremia by the following mechanism. IVIG requires a stabilizer, and the stabilizer is typically a sugar. In the past, one of the sugars that was commonly used was sucrose. Now, sucrose can be nephrotoxic and has been associated with acute kidney injury. This patient was receiving her IVIG as an outpatient without daily monitoring of the renal function and likely developed acute kidney injury from the nephrotoxic effects of sucrose. As she had acute kidney injury, additional administration of the IVIG and sucrose, the sucrose could not be excreted, was retained in the body, and caused an osmotic gradient for water to go from the intracellular to the extracellular space. In this case, the serum osmolality would not be low, it would either be normal or high, and there would be an osmolar gap. Sucrose is not used anymore for IVIG. It was well known to be nephrotoxic and has been replaced with other stabilizers, commonly maltose. Although maltose is less nephrotoxic, nephrotoxicity can occur and it is osmotically active, so it is still possible to see hyponatremia by this mechanism associated with IVIG. The second case I encountered more recently. This was a patient who had a history of cirrhosis with some mild baseline hyponatremia, about 132 or 133. He also had a history of prostate cancer that had been treated with radiation. This was complicated by radiation cystitis with recurrent hematuria. He was hospitalized for hematuria and had a cystoscopy with clot evacuation and fulguration. This procedure was complicated. There was some difficulty in removing the clot. The bladder was noted to be very friable, and there was suggestion of a bladder perforation with extravasation of fluid. His sodium preoperatively was 132. Labs were checked postoperatively and the sodium was 122. This was repeated and the sodium continued to decrease and natered at 115. This was associated with mental status changes, and the patient was treated with 2 boluses of hypertonic saline. Now, the mechanism in this case is the following. In urologic and certain gynecologic procedures, fluid needs to be used for distension and irrigation. If a certain type of cautery is used, an electrolyte solution such as normal saline cannot be used because this can conduct the electrocautery. So therefore, a non-conductive solution needs to be used. Most commonly, this is something called glycine. Now, in certain procedures where a high volume of glycine is used, the tissue is vascular or friable, there is a perforation, and the procedure is prolonged, the glycine can be absorbed into the circulation. This is osmotically active and causes hyponatremia by the osmotic gradient pulling water from the intracellular to the extracellular space. This is not hypotonic hyponatremia. It is not associated with cellular swelling, but this patient had some neurologic symptoms. The neurologic symptoms from glycine are caused by the following mechanism. First, the glycine itself can be neurotoxic. And second, one of the metabolites of glycine is ammonia. So the patient can get a hyperammonemia. So in this case, when the serum osmolality was measured, it was 282. At the same time, the calculated osmolality was about 250. The ammonia was above 200. As I said, we gave 2 doses of hypertonic saline, although it's debatable whether this was necessary or should be given, as the patient did not have hypotonicity and therefore likely did not have cellular swelling. Lactulose was prescribed but actually was unable to be given because of the patient's neurologic condition. The following morning, the serum sodium had improved to 127 and the ammonia had improved to about 40. So that's it. Some unusual causes of hyponatremia to think about in the right clinical context. If you've come across any unusual cases, please put them in the comments below. And if you made it this far, you might as well hit like, subscribe, share this video with someone who you think would be interested and want to learn about this topic. And until next time.